Uh, Good afternoon, sir. Hello.
Yes,
Okay.
yes. Speak.
Should I begin, sir?
Start.
20-year-old male XYZ living in Andheri, Hindu by religion, right-handed, works at a computer repair shop, comes with a chief complaints of difficulty walking and balancing since past 6 months, difficulty typing and writing since past 6 months. Patient was apparently all right 6 months back when he started facing difficulty walking from home to work. Patient noticed clumsiness and imbalance while walking and says had tendency to fall on the right side, which was insidious in onset and progressed gradually in the past 6 months. The patient, however, managed to continue walking to work for the next 4 months. Over the past 2 months, the patient has to take support while walking and had to leave his job. The patient also has difficulty climbing stairs since past 4 to 5 months and has fallen from stairs twice in past 1 month without any significant trauma. There was difficulty in typing and writing at work, complaints of not having control of his pen, which was insidious in onset and progressed gradually from bad handwriting to inability to write at all. Patient also complains of difficulty reaching an object, however, can hold an object properly. Patient finds it difficult to button his shirt. There is difficulty in combing hair and wearing slippers while sitting. Patient also finds it difficult to sit and stand from sitting position since past 2 months. It was insidious in onset. Patient used to sit from sleeping position without support, but now needs to hold on to reel or bed before sitting. This was insidious in onset and it gradually became difficult for patient to sit and stand and maintain his posture. Apart from this, the patient's mother also complains of change in his speech, saying that he takes a lot of breaks while he speaks, which is also noticed while talking to the patient and was insidious in onset and has not changed over the course of past 6 months. The patient has visited a local hospital where he was asked to visit Cooper. So should I continue?
Okay. So you gave a very elaborate onset duration progress. Can you just summarize again the chief complaints and the
Okay, sir.
positive finding in your ODP?
Yes, sir. So the patient has difficulty walking and has imbalance with tendency to fall on right side since past 6 months, and he this has been gradually increasing. Plus, he has difficulty climbing stairs, difficulty typing and writing. The patient cannot write and, at the current time. Also, the patient has found that there is difficulty in buttoning his shirt and combing his hair, with difficulty from sitting from sleeping position and also standing up from sitting position. The patient needs to take support while doing that, and also there is
Okay. So
change in his voice.
Krishna, can you interpret your findings?
Interpret in this sense.
And you're telling me that he has difficulty in walking. So can you localize whatever the complaints are? Can you localize each and every
Okay.
symptom?
Yes, sir. So clumsiness and imbalance, I can either localize it to the cerebellum or the dorsal column, meaning peripheral neuropathy. Uh, Difficulty climbing stairs, same, unless the patient is also involved with some eye problems, as in any palsy, which he does not complain of.
Hello,
Uh,
you are not audible.
hello.
Hello, Krishna, you are not audible.
So he's audible actually, sir. Just a second.
Hello,
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 hello.
hello. Am I
So, so,
audible now?
uh, so, am,
What's the issue?
Krishna, just one second. So, am I audible?
Yes, you
I
are
think,
audible.
Krishna, just try again.
Sir, am I audible? Hello.
Yes, you are audible now.
Okay, sir. Uh,
Ah,
should I
so
continue,
again,
sir?
start from that. No,
Yeah,
start
so
from the
clumsiness.
localization.
Yes, sir. Clumsiness and imbalance. I will localize it to the dorsal column and the cerebellum right now. Typing and writing problems, again cerebellum, because uh, uh, he has difficulty over in writing and has no control of his pen, which is typically seen with fine moments. Also, there is difficult to button his shirt, difficulty combing hair, which is problems of incoordination, and also can be due to muscle weakness. So I will involve cerebellum and dorsal column again.
No, but
It
combing his hair
finds
means
it.
it is a proximal muscle weakness, no?
Yes, sir. Proximal muscle weakness.
So you will attribute proximal muscle weakness to cerebellum or to any other.
Anterior column, sir.
Okay, so you will attribute it to an anterior column lesion. Okay, so pyramidal
Yes,
tract.
sir.
Okay.
But
Mm.
only if it is weakness and it's not incoordination. I'm thinking both. It can be incoordination as well or weakness as well.
No, difficulty in combing is definitely you have to lift the hand, na? And that involves your proximal muscle. So it comes in proximal muscle weakness.
Okay, sir.
The other thing is you're saying he has difficulty in writing.
He has difficulty in writing. He says not having control of his pen. So he used to have bad handwriting, and then he's unable to write at all now.
Okay. Can you name some, apart from cerebellum, can you name some disorders having distal muscle weakness?
Um, uh, mm, Only specific to distal muscles.
Yes. Where distal
So
muscles are more involved than proximal muscle.
myopathies.
No. So which myopathies will involve the distal muscle?
Uh, mm,
See, one
I
myopathy is
really cannot recollect now.
So one myopathy is inclusion body myositis. The other, it is not a myopathy, but anterior horn cell disease, where you have a motor neuron disease of a ALS type, where you have weakness in your fingers. Okay, weakness in your hand muscles. Okay, or you can have a mononeuropathy where, like ulnar neuropathy or a median neuropathy, where you have weakness in your fine finger muscles. So ulnar neuropathy, median neuropathy, motor neuron disease like amyotrophic lateral sclerosis, or a very hello.
Hello. Yes,
Hello.
sir. Yes, sir.
Or a variant of MND, or you can have variants of MND where you have distal finger weakness, or you can have syringomyelia also where you have distal muscle weakness because it's anterior onset disease. Okay.
Okay, sir.
So continue. So apart from your cerebellum, because he's not able to do automatic movements. Okay, you are
Yes.
saying that his handwriting is very poor. Okay. And then next symptom and localization.
So next symptom is change in speech. So change in speech can be anything. It can be bulbar, pseudobulbar palsy. It can be myopathy, myopathic. It can be due to myasthenia, cerebellum involvement. So
okay, in cerebellum involvement, what type of speech will get?
Scanning type of speech.
Okay, or any other type of speech, staccato type of speech.
Staccato.
So why you get scanning type of speech in cerebellum? Or why you have this speech disorder in cerebellum?
Sorry, sir.
Why you have this speech disorder in cerebellum?
So because of impaired timing and because of impaired timing and cadence,
No,
maybe.
the hallmark of cerebellar lesion is hypotonia. And other hallmark is your incoordination. So there's incoordination between your pharyngeal, laryngeal, and your glossal muscle, that is your tongue muscle. So there's incoordination between all these three muscles, your tongue muscles, your pharynx muscles, your larynx muscles. Apart from that, they are hypotonic also. So you have a speech which is a staccato, or you have a speech which is a scanning type of. Okay. Okay.
Right.
Continue.
Negative history. There's no history of nausea.
Any other symptom? Any other symptom, Krishna?
No, sir.
Any other symptom?
That's it, sir.
Okay. Okay. So you are going to your negative history. Okay.
Yes, sir.
Mm-hmm.
There's no history of nausea, headache, vomiting, dizziness, neck rigidity, fever, or vaccination to rule out any recent infection or post-vaccination issue or compressive or vascular disorders. There's no history of behavioral changes, seizures, spasms, or cramps or involuntary movements. No history of fatigue or weakness in upper or lower limbs. There's no history of
Krishna. Which condition
Yes.
of cerebellum will give you this dystonia or behavioral changes? Can you name any disease?
So CJD, degenerative conditions, prion disease, CJD, normal pressure hydrocephalus.
Okay. In CJDs, definitely you will have some dystonias and myoclonic jerks. Any other disease apart from CJD where you will have behavioral involvement and the symptoms you said, or psychiatric symptoms are there?
Any other disease, sir? I am not sure. Ataxia telangiectasia, Friedreich's disease, Friedreich's ataxia.
Psychiatric symptoms.
Okay.
Or any behavioral symptoms are there? Okay, we'll leave it. You can continue.
Okay, sir. So vitamin B1 deficiency, Wernicke-Korsakoff?
Yes. That answer was on the desktop only. Okay, continue.
Okay. There's no history of vision changes, diplopia, vertigo, nasal twang, or regurgitation of food or difficulty swallowing food. For cranial nerve involvement, there's no history of sensory disturbances, numbness, paresthesias, or pain. There's no history of bladder and bowel habits are normal. Patient consume mixed type of diet. There's no history of altered bowel movements, abdominal pain, and diarrhea.
Why did you ask a dietary history in this, Krishna? Why did you ask a dietary history? Is it significant in cerebellar diseases?
Sir, I asked for gluten ataxia.
Okay, one is celiac disease. Any other?
Also, sir, if the patient is alcoholic or consumes less of vitamin B12 or B1, is a vegetarian, vegan rather, so he'll come with similar complaint.
B12 deficiency. Okay. Continue.
Sleep-wake cycle is normal. History of etiology, there's no history of chest pain, palpitation, dyspnea, or edema. No history of suggestive of TB infection, fever, rash, joint pain, bleeding tendency, any recurrent infection to rule out rheumatic or immunologic causes. There's no history of polyuria or polydipsia. There's no history of multiple partners or ulcers anywhere in the body to rule out syphilis. There's no history of early morning sickness.
Krishna, what are the CNS effects of syphilis? Or the CNS lesions in syphilis?
So one is it causes Argyll-Robertson pupil. Then it can cause stapes dorsalis, which involves posterior column. Others I can't remember. So
generalized paresis of insane, GPI.
Yes, GPI.
Generalized paresis of insane. Then it causes end arteritis obliterans. So it can. Pardon?
That will be cardiac, right? I mean, I consider that
Yes,
aortitis and end arthritis, everything will be.
yes, yes, that will be cardiac, but it can have you can have some CNS that is GPI only. You can have generalized paralysis of insane because of that. That is, you will have some dementia or some altered behavior. Any other
Okay.
lesion of syphilis in neurology, neurosyphilis?
Oh, no, sir, I'm sorry.
Can syphilis cause neuropathy?
It causes peripheral neuropathy, so when it involves the
Yes.
dorsal column.
So that is one. So even you can get peripheral neuropathy. You can get Tape's dorsalis. You can have irregular pupils. That are unequal pupils, AR pupils. You can have syphilis and meningitis, syphilitic meningitis also.
Yes, syphilitic meningitis. Yes.
Okay, continue.
Past history, there is no significant past history of a previous surgery or medical admission. No history of diabetes mellitus, hypertension, convulsions, TB contact, or HIV. Personal history, patient occasionally takes alcohol whenever with friends, and whenever he does, he usually takes beer. He's a non-smoker and a non-drug abuser. Socioeconomic history belongs to a lower middle class family. Family history, the patient's father has a similar history and is on wheelchair since past 10 years. Details are not known. Bowel, bladder, sleep, and appetite are normal.
Okay, continue.
So should I summarize?
Yes, summarize.
20-year-old male comes with clumsiness, imbalance while walking, progressive in nature, difficulty standing up without help, difficulty doing fine movements like writing, typing, tying shoelaces, or buttoning shirt, and has dysarthria, is most likely a case of degenerative cerebellar disorder.
Okay, you are saying it is degenerative cerebellar disorder. So, what are the examples of degenerative cerebellar disorders?
So, spinocerebellar ataxias, Friedreich's ataxia, dentatorubro-pallidoleucine atrophy, vitamin E deficiency causes, and with hereditary ataxia, then a metachromatic leukodystrophy.
Alcoholic, common, tell a common
Yeah,
also, no? Alcoholic
alcoholic and
cerebellar
vitamin B12.
degeneration. Vitamin B12,
Will
and
cause
common
dorsal
is the
column,
other
not
is,
cerebellar.
yes. So any other cerebellar degenerative common is you see Parkinson. In Parkinson, do you see that? Multisystem atrophy,
Multisystem
MSA
atrophy.
with
Yes.
C, MSA C. No,
Yes,
MSA
sir.
category C, no? That contains more of cerebellar involvement.
Cerebellar.
Okay.
Multiple sclerosis.
They are not degenerative, but no?
Inflammatory.
What we, they are demyelinative, inflammatory. Okay.
Yes.
So continue your general examination.
General examination. Patient comes to OPD with help of relative along both the sides of the patient, holding the patient, and patient has a wide base gait. Patient is well built and moderately nourished. Temperature, he's febrile, blood pressure of 134 by 84 mmHg, bilateral and upper limb taken on supine position. Respiratory rate is 18 per minute, regular. Pulse 80 per minute, regular. Good volume, normal character, equal on both sides in radial artery. Peripheral pulses are felt, regular. No evidence of atherosclerosis in peripheral arteries. Cardiac brew is absent and no apex pulse deficit found. Attitude, patient was lying supine, arms by the side of the body, and both legs were fully extended. Pallor, icterus, cyanosis, clubbing, lymphadenopathy.
What is the attitude, Krishna? What is the role of attitude in or decubitus in cerebellar lesion?
Uh,
What if the patient is sitting?
So
Then what
that
you conclude?
if the patient is sitting, that shows that the vermis is intact.
Yes. So he doesn't have any postural instability, or the
Yes.
axial instability is not there. Okay. Okay. Continue.
Higher function, patient is conscious, cooperative, conversant, well oriented to time, place, and person. Immediate, long term, short term memory is intact. Patient is right handed. Speech, scanning type of speech. Patient takes time to speak and breaks between alphabets of words. Comprehension is normal. Reading skills are normal. Patient is unable to write from right hand and barely writes from the left hand. Repetition is normal. So I wanted to ask about repetition that in a case of cerebellar atrophy, cerebellar dysarthria, will we be able to check repetition properly? Because the patient will take anyways a lot of breaks between words.
Yes. So repetitions, you won't be able to check repetitions, or even any complex speech test cannot be tested when you have dysarthria.
So repetition I should not mention in the examination, right? Or rather
If it is
say that
significant, then only mention. Just talk about dysarthria and the speech, rather than talking about the different parts of speech, because it would be difficult for us to test in these patients.
Right, sir.
Okay.
Okay, sir. Cranial nerve examination. Olfactory nerve, normal both in right and left. Optic nerve, normal both in right and left. Oculomotor, trochlear, and abducens, both are normal in right and left. Ocular examination shows horizontal nystagmus with fast component towards the right side. It is mild and not diminished by visual fixation.
Okay. So what is nystagmus?
So nystagmus are involuntary jerky movement of the eyeballs.
Repetitive.
Repetitive.
They are repetitive, no? Yes. Of
Yes,
the
sir.
conjugate of both the eyes, and they are
Yes, sir.
gaze provoked. Even if you are staring, you can have nystagmus, or if you are looking towards the right or left, you can have a nystagmus. So what are the different nystagmus movements?
So there is pendular nystagmus. There's gaze evoked nystagmus. There are according directionally there is vertical torsional nystagmus or horizontal nystagmus. The physiological nystagmus is optokinetic nystagmus.
Okay. So tell me different eye movement. Hello.
Yeah, sir.
Continue. You are saying something about nystagmus.
Yes, sir. Other nystagmus that can be dissociated nystagmus can be seen, and seesaw nystagmus can be seen. So these are other two.
Dissociated nystagmus and seesaw nystagmus. Okay.
Yes, sir.
Okay. Continue. One more question. Cerebral nystagmus, vestibular nystagmus, how you will differentiate?
Okay, so in cerebellar, lesions of fast component will be ipsilaterally, while in vestibular, it will be the slow component will be ipsilateral. The fast will be contralateral, the side of the lesion.
Okay, 1 second.
So associated symptoms we have to see: vertigo, dizziness, vomiting. They are usually involved in vestibular lesions. Cerebellum will not involve them. And also cerebellum, we'll see more of ataxia and everything else. So
okay, so one difference is you are saying that in cerebellar nystagmus, the fast component is toward the side of the lesion, while in vestibular, the slow component is toward the side of the lesion.
Yes,
Second, you are saying according to the symptoms, you will have vestibular symptoms in vestibular nystagmus and cerebellar symptoms in cerebellar nystagmus.
Yes, sir.
Third thing is cerebellar nystagmus occurs more even during your gaze fixation. Even if your eyes are at rest position, still you will have cerebellar nystagmus. Third thing is cerebellar nystagmus is bidirectional. That is, Even if you look towards the right or towards the left, the nystagmus is going to be there. Okay, and that is a bidirectional nystagmus, where the fast component will be towards the side of the lesion, while the nystagmus in vestibular is not bidirectional. Means if you are looking, if you have a right ear problem or right vestibular problem, the nystagmus will be better seen or better appreciated in the right gaze rather than at the left gaze. While in cerebellum, the nystagmus is bidirectional. That is, it is seen when you look at the right side also, as well as if you look at the left side also. So these are the difference between cerebellar and vestibular nystagmus. Okay, continue.
So I had a question. Few
Yes.
books say that cerebellar nystagmus changes with direction. So what does that mean?
No, I don't have. I can't explain this thing because I've never read about this. Whether it changes with direction, but classical description of cerebellar nystagmus is it is bidirectional. So
Okay,
it is you look either on the right or on the left, you will have a nystagmus with the same intensity. While the fast component will always be towards the side of the cerebellar lesion.
Okay, sir.
Okay, continue.
Uh, Trigeminal nerve examination, right side and left side both are normal. Facial nerve, normal, both sides. Vestibulocochlear examination, normal on both right and left side. Glossopharyngeal and vagus nerve, normal on both right and left side.
Suppose if
Spinal
the facial
accessory
nerve,
and...
Krishna, if the facial nerve is damaged,
Yes, sir.
or if you have a facial nerve involvement, you see what with cerebellar ataxia with facial nerve involvement, what you'll think of?
Lateral medullary syndrome, sir.
फेशियल लैटरल मेडुलरी कहाँ आता है? मेडुला में तो
sorry,
9
no,
10 8 9 10 आएगा ना. हाँ, so if you have a facial nerve with ataxia,
cerebellopontine tumors, schwannomas or something.
Schwannoma, yes, but in schwannoma any other nerve is involved apart from facial nerve?
Yes, so the 8th nerve will be involved.
8th nerve also. I am talking about just 7th nerve and your ataxia. It is from Miller-Fisher syndrome. Miller-Fisher, no? It's a GBS variant.
Yes, sir.
GBS variant. In Miller-Fisher, you have ophthalmoplegia, you have ataxia, you have descending paralysis, and you can have facial nerve involvement, bilateral. Okay.
Right, sir.
So now coming to another, you have the ataxia, you have cerebellar along with dysphagia.
Sorry, sir, I didn't get your question.
The patient is having 9/10 nerve involvement. Along with that, the patient is having cerebellar involvement. So any lesion you can think of?
Cerebellar involvement. Then lateral medullary syndrome, sir.
Yes, lateral medullary syndrome, where you have not the cerebellum but the spinocerebellar tract involvement.
Yes,
so
sir.
you have the 9/10 nerve involvement as well as you have the ipsilateral spinocerebellar involvement. And also in multisystem atrophy, also MSA, Shy-Drager syndrome, you will have some autonomic dysfunctions, including dysphagia also. So that is not very common, but lateral medullary is very common. Okay, continue.
Okay. So motor examination. Nutrition, no wasting of muscle. Upper limb, right and left arm circumference below and above olecranon process is within normal range. Lower limb, right and left circumference below and above patella is within normal range. Passive tone is normal. Joint, shoulder joint, flexion, extension 5/5 on both right and left side. Elbow, flexion, extension 5/5. Wrist, flexion, extension 5/5. Fingers, flexion, extension 5/5, both on right and left side. Hip joint, knee joint, ankle joint, toe joint, flexion, extension, both on right and left side is 5/5. So there is no power deficit. power is normal. Sensory examination, superficial touch,
Hello?
pain. Hello, yes, sir.
Hello?
Hello, yes, sir. Hello.
Krishna, I'm not able to hear you. Again, tell the reflexes lower limb.
So reflexes not yet done. Only the power I've checked.
Okay, power.
Only the
Power of the lower limb. Tell me about power of the
Yeah.
lower limb.
Both. It's normal in both the limbs.
Oh, in both the limbs. Okay.
Yes.
It is 5 by 5.
It is 5 by 5.
Continue.
Superficial touch, pain, temperature present, deep pressure, deep pain, vibration sense, position sense are present, cortical sensation, tactile localization, 2-point discrimination, stereognosis, and graphesthesia is present. Reflexes, lower limb and upper limb reflexes are present, knee, ankle, biceps, triceps, and supinator present in both the right and left side. Superficial reflexes are present on both the sides.
Krishna,
Yes,
what get in cerebellar disorder and why?
Sorry, sir. Sorry, sir.
What type of knee jerk? What type of knee jerk you will get in cerebellar disorders and why?
Sir, we'll get a pendular knee jerk. Pendular knee reflex
Okay,
is
why?
present. And
Why?
it is present because of dysmetria. Hello.
Hello?
So there is no control of the
No, it is present because of
control. Hello, because of loss of control of the jerk, sir. Hello.
No, it is because of simple hypotonia. If you have hypotonia, once you tap the tendo Achilles, you will have a swinging leg. And if it is 5 or more than 5, it is a pendular knee jerk. Okay, it is because of hypotonia of the muscles, including the quadriceps.
Okay, sir.
Okay. Then you talked about dysmetria. What is dysmetria?
So dysmetria is when a person is not able to judge the length.
Okay, so there is overshooting or undershooting.
Overshooting.
Okay, while trying to. So it is overshooting while reaching an object.
Yes, sir.
Okay. Continue. Then
pendular knee reflex is present in both right and left side, and flexor plantar reflex is both. There is flexor plantar reflex in both right and left.
No, I talked about ankle reflex.
So it's present. A lower limb, knee, and ankle both are present, right and left.
Okay, so tell me a cerebellar disorder where you have cerebellar symptoms with absent ankle.
Friedreich's ataxia.
Any other?
Subacute combined degeneration.
Okay. Any other one is hypothyroid also, apart from Friedreich's ataxia. You have cerebellar as well as you have absent ankle jerk. Okay, continue.